Good morning, everybody. Welcome. We are now convened for a work session of the Anchorage Assembly. We're here to take up the AM 862-2024. That is Executive Appointment Confirmation Hearing, George Conway, Chief Medical Officer. Today is October 22nd, 2024. In the Teams environment, I want to ask the clerk to take the roll of members. Madam Clerk.
Thanks. Forgot about this part. Chair Constant.
Here.
Vice Chair Zalatel is
Excused.
absent. Assembly Member Littlefield.
Here.
Assembly Member Myers.
Here.
Assembly Member Bronga.
Here. And Chair, I think you said 2020 or, oh, I thought you said 1024. I'm sorry. I get it.
Assembly Member Rivera.
Present.
Assembly Member Volland.
Happy to be here.
Assembly Member Solt is absent.
So, Ms. Braga, I think you're correct. I did misdate the item. So I'll correct that in a minute.
Assembly Member Presverdia is not here. We only go around the room, right? We don't announce who's absent. We just go around the room and say who's present.
It's the members. Yep. We don't need
Okay,
to.
so everyone, that is who is present.
All
Chair
right. Thank
Constant,
you very
Mark
much.
Littlefield, Karen Bronga, Scott Myers, Felix Rivera, and Daniel Volland.
All right, and I'll start back over. Today we are here to have a work session on AM 862-2024 Executive Appointment Confirmation Hearing, George Conway, Chief Medical Officer. Today is 11/1/2024. I read the date October 22nd because that's the date it was originally introduced onto the record, and thank you for catching that, Ms. Bronga. So the general proceeding for these work sessions is I will hand the microphone to the municipal manager who's here on behalf of the mayor. So, Ms. Wynn Pearson.
Thank you, Mr. Chair. And thank you, members of the Assembly. And good, I guess it's not quite good afternoon. Good morning, good late morning. It's my pleasure today to introduce for potential confirmation to the role of Chief Medical Officer, Dr. George Conway. Dr. Conway comes most recently from serving as the Director and Health Officer of Deschutes County, Oregon, where he led a team of more than 400 public and behavioral health providers while offering clinical services. He's taught at the Oregon State University College Public Health since 2018. Dr. Conway holds a doctorate in medicine from the University of New Mexico School of Medicine and a master's of public health from the University of South Carolina School of Public Health. He was a medical officer in the U.S. Public Health Service who retired at the rank of captain. His professional skill set includes public health, emergency preparedness, and epidemiology, as well as preventative family and occupational medicine. Dr. Conway led Central Oregon's regional response during the COVID-19 pandemic, including collaborative and executive working groups, wastewater surveillance, and mass immunization clinics. He developed the Deschutes County Stabilization Center to treat acute mental health crises, provided technical assistance for natural disasters like wildfire and smoke events, and he helped rebuild the county's communicable disease program to address everything from long-term care facility-related infections to STIs and HIV/AIDS. Dr. Conway has worked across the globe from serving as a senior medical officer and epidemiologist for the CDC, advising and training field epidemiologists for programs in Asia, Africa, and the Middle East, to working as a public health attaché in the U.S. Embassy in Beijing. And Dr. Conway has critical experience here in Alaska. From 1992 to 2011, he was the director of the CDC National Institute for Occupational Health and Safety Pacific Regional Office here in Anchorage, where he helped plan and direct preventative measures to reduce occupational deaths in Alaska by 67%. who worked with the aviation industry to prevent occupational fatalities from air crashes, established a national research group for the occupational health of the oil and gas industry, and worked with the Indian Health Service in the state of Alaska to study occupational injuries for Alaska Native people, including developing a unique system to measure substance-related injuries. His extensive experience, training, and dedication, we think, make him a great fit to become the municipality's chief medical officer, and I'm pleased to recommend him today for confirmation in the role.
Thank you. So, Mr. Conway, generally speaking, we now allow the confirmee to make a statement. So you have the floor.
Great, thanks very much.
So confirm to state that Anna Brawley joined at 11:44.
Thank you. Mr. Conway.
So, okay, thanks. Hi, and it's when Pearson, thanks very much for that introduction, and actually that will substantially foreshorten the summary I put together. Is it okay if I just talk for a few minutes to sort of augment what was said?
You have the.
I'm sorry, it broke up. There's people that are still trying to get in. Okay, there we are. So, good morning, Assembly members, and thanks for the opportunity to talk with you today. My first time working in Anchorage was in 1981. I was outfitting a scientific expedition that was conducted in the Brooks Range, gathering Arctic soil samples for development in new antibiotics. That summer, I fell in love with Alaska and felt that I needed to come back and live here. But that took a few years. I'm a public health physician, as mentioned, and it's already been mentioned that I did my training in South Carolina, in New Mexico and South Carolina. I was fortunate enough to work on the Navajo Indian Reservation before that as well. I was commissioned in PHS in 88 rather, and then I served as an EIS officer and as the HIV/AIDS consultant in the Indian Health Service. I came to Anchorage in Alaska very frequently. During that time, we set up a HIV reference laboratory here, and we also set up a key surveillance point in Kotzebue. I was also asked by Senator Stevens' office to be detailed to his office and then come here and work up and advise on a local response to a community HIV outbreak in the Cook Inlet area. As mentioned, I transferred to Alaska, served as the initial chief and then a regional director for a second CDC field station. The other one is the Arctic Investigations Program, which deals primarily with communicable diseases and was very instrumental in helping with mounting multiple large investigations and testing immunizations. We were indeed fortunate to be able to be instrumental in decreasing the occupational death rates substantially in Alaska. And I was also asked to lead one of the working parts of that, the Alaska Interagency Aviation Safety Initiative, which was a congressionally mandated and funded initiative, which was in collaboration with FAA, NTSB, and National Weather Service from 2000 to 2004. And it was a relatively formal thing with some hearings and things like that. We also were involved in founding the Medallion Foundation, which was a collaboration with industry, and that collaboration and the sort of senior airman committee that we formed was instrumental in promoting the idea that flying where you could not see is ill-advised. So that tends to result in controlled flight into terrain, which is the most dreaded form of aviation accident. I was in Anchorage working for 20 years, from 92 to 2012. And during that time, I'll just enumerate a few of the things I did locally in addition to my day job. I was involved in the development of the Anchorage Safe Communities Program, which is now called the Alaska Injury Prevention Center, and I served as the founding board president for that. During the Maestrom administration, there was something called Anchorage Healthy Futures, which is very inclusive planning and discussion effort to try to improve the health in the city. I served as the Healthy City Working Group co-chair and also as the research consultant for the group. And that was 95 to 98. I was during part of the year I was here, the International Union for Circumpolar Health was located at or officed at the Institute for Circumpolar Health Studies at UAA. And I was fortunate to serve as both the president of the American Society for Circumpolar Health and of the International Union for Circumpolar Health from 96 to 2000. I served as the consulting physician for the Health Curriculum Committee for the school district, Anchorage School District from 99 to 2002. As one of the Anchorage Health and Human Service Commissioners from 2006 to 2009. I was the physician of record for the AMATS, or the Air Quality Advisory Committee, from 2009 to 2012, and a member of the U.S. delegation for the Arctic Council's Emergency Prevention, Preparedness, and Response Group. As mentioned, in 2012, I was sent overseas by CDC to serve as a senior advisor to the China Centers for Disease Control, providing training and advice in outbreak investigation containment, as well as air pollution hazards and mitigation. My diplomatic assignment, titularly, was as the U.S. Public Health Attaché to China at the U.S. Embassy in China, but it's actually a place which was very interesting in the Chinese Centers for Disease Control. So I was the only Waiguaran or foreigner among over 1,000 Chinese scientists and physicians there. I also served very interesting 6 months as the senior medical officer for the UN mission for Ebola emergency response in Liberia during the 2014 and 2015 West African Ebola outbreak. The work I did in Deschutes County was mentioned. I feel fortunate in that I was able to survive giving thoughtful, scientifically based public health advice in an environment which didn't always welcome it. And I was able to stay on until the pandemic was, for practical purposes, at or near its end. I'll just add that I'm very happy and grateful to be back working in Anchorage. With children and grandchildren living here, I continue to have a very strong personal interest in doing what I can to do to improve the health and well-being of people of Anchorage. And of course, that's what will impel me to be waxing skis this weekend. Thanks very much for your support and the opportunity to return to and assist in my hometown.
Thank you very much. So just to the members, process-wise, text or put in the chat that you would like in the queue. I'm managing the queue from here, and I'm going to sneeze. I'm sorry. And please don't put anything substantive in the chat, as the chat is not part of the public record, and so nothing. It doesn't count if you put it there. So I just have to get in the queue. So and in our process, Dr. Conway, we just ask questions. Members can put themselves on the list, and we'll go through the process. So I have a couple people now. Ms. Brawley, go ahead.
Yeah, thank you. And thank you, Dr. Conway, for volunteering. You actually answered a lot of my questions just from your overview, because I was going to ask really how you see your role intersecting with public health and really population level health. So I think your background really speaks to where your mindset is on that, in addition to obviously a doctor's role or medical officer's role with individuals. But I guess my question is, and speaking from your prior experience and now, how do you see your role and really the health department playing a positive role in reducing health disparities? So I mean, socioeconomic, racial, right? There's a lot of different populations, of course, that we serve, and we know that continues to be an issue. So just wondering if you have specific thoughts or just in general what your philosophy is as far as keeping all of our community members safe, knowing that there's a lot of folks who are not starting from a great baseline based on factors outside their control. Thanks.
Sure. Well, there's actually a very strong tradition in public health going back to the last part of the 19th century of public health being heavily intertwined and often promoted by people that were also advocating for equity and justice. and for many services. And there were things like trade unions and advocacy groups. And during the women's suffrage movement, it was a very major element of sort of social progress. And one of the subjects of the New Deal, the part of the premise of the New Deal at the tail end of the Great Depression was that many people did not have services at all. So that was implicit in a lot of that planning. For a while, this was described early in my career as socioeconomic status, sort of an abstraction, statistical. But I think in the last 10 years, maybe 15 years, the central motif of equity being part of the focus of the whole public health enterprise is central. The underserved people, people that are, whether they're haven't had good opportunities, whether they're unemployed, whether they have chronic illness, disability, psychiatric illness, addiction, are all key parts of our clientele, both for clinical services and also for outreach and to try to prevent things. I was at the newly managed congregate center at the solid waste facility for homeless people earlier this week. And it's a very austere setting, but I'm hopeful that with Catholic Social Services management and a very, very dedicated staff that we can help with that as well. The public health activities of the health department are central to our mission. So we provide clinical services, but also things like outbreak response, environmental wellness, whether it's restaurant inspections, et cetera. So it's the whole breadth of it. And clearly probably the highest value and strongest focus is trying to help level things for people that are having challenges. Is that a sufficient answer, or is there something particular you'd like me to answer about?
No, I think that was a good overview. Thanks. And I know as you get into this role, there will be more details.
All right, Ms. Braga.
Thank you, Chair. Welcome, first off. I'm really excited to hear you like to ski, Mr. Conway, Dr. Conway. One of the things that I wanted to ask you is we have worked on a few resolutions that deal with, they're not directly like a medical thing, but out of kids' hands was a recent resolution that called on limiting access to diet pills and muscle building supplements for those under 18. We're looking at mandatory ID checks in liquor, not just in package stores like it is now, but also in settings of bars and restaurants. And then safe gun storage is another thing that I'm interested in. How do you see your role interplaying with helping with some of these larger safety initiatives?
Well, I think that the three things you mentioned are implicit to our role. We certainly don't want children getting into most of those. The diet pills are strong stimulants, esketrol and whatnot, and they're controlled substances and prescribed specifically for the person they're prescribed for, and whatever can be done to limit that access, as long as it's structured to be effective and not punitive, I think would be good. Mandatory ID checks are sort of a norm in many states, and I really haven't found that to be an inconvenience. The red stripe regime makes sense for both people that are underage and also people that have had alcohol-related convictions or serious problems. Safe gun storage is one of sort of the paramount concerns that I have. I was actually there were two things that I was involved in the 90s with the state health department and some local coalitions. One of them was photo radar, which was sort of an especially in school zones, which was sort of a very controversial thing. And I'm not sure I'd do that again, but it was interesting. But the other was trigger locks and safe storage of especially handguns, but also long guns. And that was actually one of the subjects, both at the state injury uh, group within the state health department and safe communities and the healthy futures all had as part of our agenda. So I think those are all really important. And one of the things that's changed a lot that I haven't seen much promotion about, but many of us have owned firearms because of bears. I remember riding shotgun when my kids were little, picking berries, and I would stand there with this shotgun, which is kind of, I mean, not great, and going out in the field. But now pepper spray is so effective at dealing with a bear, and the bear will probably survive, which is good too. That I actually think a lot of the utility for especially long guns for defense against animals, particularly bears that you bump into, et cetera, is probably superseded by that. Still, I mean, if you want to go on the North Slope or on Barrow and whatnot, you'd better have somebody that has a really, really strong firearm. But so actually, I've actually just gotten rid of most of my high power firearms that I've had for many years. And I just carry pepper spray. And you don't want your kids spraying it on each other, but it's not going to kill them. So that's and actually, so I think that gives another tool. And tasers were talked about as non-lethal weapons years ago as a substitute for guns, but they can really hurt people, and that they're not a casual use thing. But the advent of pepper spray and I have friends that have been saved by it, and the demonstration of the effectiveness, I think actually should be promoted to, if not supplant or replace, then at least be a good thing for people to carry and probably make. But carrying even a short barrel shotgun that's Parkerized or something like that, it weighs a lot, and the rounds weigh a lot too. And the pepper spray is a lot more convenient. Once again, if there's an accidental discharge, everyone will be well seasoned but survive.
Thank you for that.
All right, next in the queue, I have Mr. Boland.
Thank you. Thank you for being here, Dr. Conway. It's great to have a candidate with your background. I have a couple questions. I guess actually I have three questions. One is sort of along the lines of what Member Bronga just brought up, is the role of the Chief Medical Officer as policy advisor both to the mayor and assembly, and how you would see that. Are there issues that are sort of on your radar that you want to bring forward? Do you see that role as being more passive or more active, where you're bringing things to the administration and to the assembly? So that's question number one. Question number two pertains to challenges, major challenges at the Anchorage Health Department. These have been ongoing. Employees at the health department have been through a lot due to poor former leadership, and people who were put in key positions who did not have the actual experience or background that they claimed to have. And we saw, a hollowing out of the health department. I think at one point we were nearly at 35% vacancy, and I know that our acting director Kim Rash has worked to rebuild that department as best she can. But I'm curious about your role, being in leadership at the health department, how you could help create a more positive culture, and particularly with the employees that you would be interfacing with on a daily basis. And then my third question is that pertains to the emergency powers of the Chief Medical Officer. I think under normal circumstances, the average person in the public has no clue who our Chief Medical Officer is. But certainly in the instances of a pandemic, the public tends to pay more close attention for a number of reasons. But the emergency powers of the Chief Medical Officer are somewhat significant. And one of the reasons that I wanted to create a requirement for assembly confirmation, so that we could have this conversation with you and we could hear feedback from our constituents on appointees that are put forward. And so just want to hear from you about your understanding about what those emergency powers are. Thanks.
Okay, I'll answer in reverse order. I know there are emergency powers. I know they're written in public health law. I actually do not have the particulars of those in front of me, so I couldn't really comment on that. If somebody has a coherent summary or wants to send the germane statutes or regulations, I'd be very happy to comment on it. In general, public health officials come to the fore when something goes haywire, whether it's a epidemic, mass event of poisoning, mass casualty event. Those are all within the purview of the kind of responses we're involved in. Your first question about policy advisor to the mayor and assembly, I'm very comfortable with that role. That was central to what I did in Oregon. It's been central to a lot of the work I've done throughout my career. I was a credentialed diplomat advising a foreign country, which wasn't always on the same side as us, and helping get through things like air pollution incidents and outbreaks. So I feel pretty comfortable with that, about that. As far as passive versus active, I'm someone who probably only has limited restraint when I see something that I think is wrong. And so I think the most glaring, I'm reluctant to say this because I've only been back in town for a couple of weeks, but the snow is upon us. And I did note that the point in time count for homelessness went up this last January, 1,700 people that are either intermittently or permanently unhoused. And I do notice, I think I'm noticing more people on the street than I was accustomed to during my many years living here. And it's winter. And if I was going to choose, there's massive homelessness in Southern California and Central California, I saw in coastal Oregon and whatnot. But, when you get to a place that gets as cold for as long here, and then in Anchorage in particular, because not only gets cold, but it gets intermittently wet. So how would you keep your things dry? It's quite bad. And I'm very interested in seeing what way I might be able to persuade a more robust response than and better accommodation than the sort of meager arrangements that there are right now. I was at the solid waste facility the other day. I was heavily involved in Oregon in forming what was called Central Oregon Fuse, which was an organization to develop and promote and then fund and build permanent supportive housing. And you have to realize that a portion of the people that are especially long-term homeless are people that have physical disabilities, chronic mental illness, drug addiction, et cetera, and having them be sort of at the mercy of whatever limited facilities are available for mass sheltering in the middle of winter isn't really the right or comprehensive solution. And I won't be reluctant to point that out, but I'll try not to be a nuisance in doing so. And then the challenges at the health department. So a leadership failure is a real problem. It can have a sort of a life of its own. The way I think you protect yourself is by careful and routine vetting of people that you're going to be trusting to have important roles. And I don't mind being so vetted. The health department is populated so far. I've met probably more than half the staff in the last 10 days or so while here. Actually, a couple weeks now while here. The people are calm, even-tempered, generally very knowledgeable. They're working very austere conditions. This building was regarded, I've been in many, many meetings in this building over the last 30 years, actually, yeah, over 30 years. And this building was considered sort of a shambles and derelict 30 years ago. And it doesn't seem to be much improved since then. I noticed that some of the windows are glued shut because they can no longer get parts for the window opening devices and securing devices. So the other thing is, I did note when I applied for this job, and I was talking to other people, I'm very skeptical. I haven't seen the stats, but I don't think that the compensation for especially professionals in this setting is anywhere near the sort of going market price. And I think that makes it very difficult, or market wage. And of course, the benefit system in Alaska, since it for quite a few years now doesn't include a pension, is lacking one of the sort of normal perquisites for people that are in long-term government service, because the 401ks, et cetera, basically shift the risk to the employee, and people that are good enough at math to work in public health will grasp that. Having said that, though, in the warren of sort of very tired-looking clinic rooms that we have downstairs, people are doing very good work and dealing with a very challenging clientele.
All right,
Yeah, I
so
appreciate
I'm
Can
going
I
to jump in there.
just
Danielle.
one note
Go
to
ahead.
Becky? Make sure that the good doctor has the specifics of those emergency powers, because I want him to know what he's signing up for. Thanks.
So I'm just going to jump in and say that because the timelines of our confirmation hearings have been going very quick, we scheduled them all for half an hour instead of an hour. Clearly, we could spend plenty of time having a conversation with Dr. Conway, but we are out of time for what we are scheduled to take on at this point. I will leave with a philosophical question that doesn't require a response. We can talk about it later, and that's just why would you come back to the municipality? And so that's the question I look forward to chatting with you about at some point. And very glad you're here. And with that, I'm sorry we don't have more time.
Thanks very much.
All right. We'll have this item back before us on Wednesday next week at our regular meeting the day after the election. So we'll be reconvening in about 8 minutes for confirmation hearing for Susie Marshall, IT Director. Thank you, everybody.
Thanks for being here.